I will now have a brief introduction about neurotoxins. The history of neurotoxins starts in 1793 in Germany in Wielbad, after an outbreak linked to consumption of blood sausages. It has become known as botulism because botulus in Latin is the word for sausage. In 1897, the clinical illness of botulism was eventually linked to an exotoxin that's known coming from the anaerobic bacterium Clostridium botulinum. And they're saying that it is the most poisonous substance known on Earth. And it has been theorized as 1 gram of the pure toxin could kill 1 million people. So many years later, in 1897, Van Ermingen investigated the outbreaks again of botulism involving 34 individuals who consumed raw salted ham, and that was in Belgium. A later outbreak in Germany again with white beans, and established that there was a second type of botulism. Within 50 years, they realized there's distinct toxic serotypes of about 8 from the letter A to letter G. And since the autonomic system uses acetylcholine as a neurotransmitter, so the idea of therapeutic use was put forth many years later, as time would prove the parasympathetic nervous system could be harnessed to treat such conditions as hyperhidrosis, sialorrhea, rhinitis, and sphincter spasms. In the late 1940s, Dr. Edward Schwartz and Dr. Alan Scott, they had medical progression, and in 1960 and 70, the FDA approved it for strabismus in 1977. So in 1980, the Dr. Jean Carruthers, an oculoplastic surgeon in Vancouver, was treating blepharoplasm with it, and one of her patients realized that his glabellar wrinkles were gone. So she shared that with her husband, Alistair, a dermatologist who has treated one of his employees in the glabellar region with the botulinum toxin, and that was the first cosmetic treatment in history when it was performed. And the first publication on cosmetic use of botulinum toxin for cosmetic treatment was in 1992. So after significant investigation, Botox was approved by the FDA for treatment of strabismus and blepharospasm. In 2000, started to be approved for cervical dystonia, and also was approved as MyoBlock in the US. In 2002, Allergan achieved the FDA approval for Botox for glabellar use, and in 2004, it was approved for axillary hyperhidrosis. In 2009, the sport was born in the cosmetic industry by Ipsen, and in 2010, Xeomin was developed by Merz. So the theory behind could fill multiple textbooks, as it include extremely complex and numerous steps, reaction, activations, and deactivations. So when the neurotoxin is injected, toxin enters the presynaptic nerve ending by endocytosis. And the light chain molecule cleave the snare 25, required that for membrane fusion and acetylcholine release. So this prevents acetylcholine being released into the presynaptic junction or cleft, and that prevents the communication between the nerve and the muscle. Now, this chemical denervation is permanent. Now, the reason for the delay is the time required for the storage vesicle of acetylcholine within the presynaptic motor end plate to be depleted. Although the binding of acetylcholine is permanent, the paralytic effect only persists 2 to 6 months. The recovery phase of the presynaptic neuron occurs when axonal sprouts arise from feedback of the inactive muscle, and reactivation of acetylcholine release re-establishes the neuromuscular activity. Aging and the male face. So we understand the aging process of the muscles, the effect on the muscles, and how we can reverse it. The same thing forming all the lines from the forehead down to the platysma bands and the horizontal necklines. We will be studying all the muscles and how we can get this calibration and working on deactivation of certain muscles within reason. So is understanding the problems and offering the solution. So these are normal patterns which I would not like you to use, and it has to be very well tailored to the patient and exact need for how we can give the symmetry and the equilibrium between the different muscle groups. So the facial rebalancing, the eyebrows between the elevators, the frontalis muscle, and the depressors, orbicularis oculi muscles, the corrugator and depressor supercilii, and the procerus muscle. The lip and jawline, the elevators of the lip are the LLSN, the levator labial superioris, the zygomaticus major and minor, and levator anguli oris. And the depressor is the depressor labii inferioris, the depressor anguli oris, and the platysma muscle. Regular repeated treatment with botulinum toxin in the upper face prevents new wrinkle formation, lead to continual sustained improvement in the appearance of deep static wrinkles. The position and shape of the eyebrow are central to the aesthetic evaluation of the face, particularly in men, and should be considered in advance of any and all treatment of botulinum toxins of the upper face. So typically women have more arched eyebrow, and you can release the eyebrow to a foxy eyebrow and to be aesthetically pleasing, while men accept and prefer a flatter, less arched brow. Because the treatment of the glabella, forehead, and crow's feet regions can individually alter eyebrow shape and position, they are often assessed and treated together, and we aim at balance and harmony. A typical pattern for the frontalis, corrugators, procerus, orbicularis oculi, and nasalis. The muscle action for the three main treatments we do every day, for the frown line, forehead, and crow's feet, to deactivate the muscles as a cause of forming the wrinkles around these areas. This is a different pattern again, and I wouldn't call it a pattern. I would only say it's following the need of the patient for the wrinkles to be treated. The crow's feet before and after, and the crow's feet points which we use conventionally, and we can do additional points as well, as long as we stay away from the orbital rim by 10 millimeters. So keeping all injections away from the bony orbit can prevent the eyelid ptosis and extraocular muscle involvement. So when we're considering needle placement, it's important to keep in mind that the muscle are not necessarily directly under the wrinkle, because the variation amongst patients, the most accurate way to inject is to ask the patient to animate the area, to be injected and observe the main areas of muscle action. For experienced injectors, the glabella, frontalis, lateral canthal region injections are not standardized, and the area of maximum muscle contraction is generally consistent by injecting in a common pattern. It is, however, helpful to have the patient activate dynamically these muscles and follow exactly and precisely. Bear in mind that the diffusion of the botulinum toxin is about 10 millimeters around the injection point. Some measurements, which we will learn, starting from the maxillary prominence all the way laterally and posteriorly, around the crow's feet exactly where the wrinkles are, the lateral canthal wrinkles, before and after. The danger zone is the injection of the infraorbital region laterally because of the zygomaticus major and minor muscle that can produce a disanimation of the lip. Muscles of the glabellar region, forming the corrugator crease, the skin dimpling with greatest muscle thickness, the 11 or the 111 formation, the bulge that is best to treat, and it can be in two heads of the procerus muscle, and in the glabella, how we can treat with only 20 units of toxins and the same thing and release of those neuromodulators. Typical pattern, but obviously this can be moved and changed regarding the maximum line of contraction, different patterns or different needs rather than a pattern to achieve the results you are looking for. So the frontalis is the only elevator of the brow, and it ends at the temporal crest. Although there is no muscle elevation lateral to the temporal crest, there is traction of the brow from the orbicularis oculi, which is unopposed by the frontalis. So deactivating the orbicularis may allow the lateral brow to relax with slight elevation during animation. So treating the lateral canthal wrinkles, the crow's feet, may also assist in components of brow elevation by further relaxing the lateral orbicularis oculi, which can pull down the lateral brow. 3-unit injection of the tail of the brow, and also in the lateral orbicularis muscle fibers, can assist relaxing the retraction force of the orbicularis oculi. So it's about harmonization that we reached between depressors and elevators across the brow. The harmony of the muscle may be more apparent when the patient animates. So the brow lifting points, and beware of the levator palpebrae superioris and how the 10 millimeter diffusion of the toxins can involve the intraocular structure. So here you can see clearly the frontalis treatment with brow elevation. And the most important and the most that patient loves the most is elevation of the upper eyelids, which make a huge difference. The nasalis muscle, or for the bunny lines, again, the bunny lines before and after, same here. So the Botox sign is when you know a patient or you know a friend and suddenly all these muscles are relaxed. The nostril flare, and this is activating the lower nasalis fibers. Rarely requested really in my practice, but the alar flare sometimes when the patient becomes self-conscious of it. So injecting 1 or 2 units of botulinum toxins in the lower nasalis fibers can relax the lateral alar nasi. Nasal tip elevation by deactivating the depressor septae muscle for the upturn of the nasal and leading to upturn of the nasal tip. And it's a common practice when I do thread lift of the nose is to inject a couple of units for the depressor septae muscle and release more of the nasal tip of the nose. Oral commissures can be obviously affected by the depressor anguli oris, which is 1 centimeter laterally and inferior to the oral commissure. Simply 2 to 3 units of botulinum toxins would help to release the muscle. The longest name of a muscle in the body, levator labial superioris aliquot nasi muscle, and we use this a lot to release the gummy smile and decrease the sudden contraction of the muscle. So the urban myths of neuromodulator: you can't lay down for 4 hours after receiving neurotoxins. You can't exercise that day. You cannot fly in a plane that day. I tell my patients to do whatever they wish, and I inject many patients on the way to the gym, tennis match, and traveling flight crew. Lying down, the glabellar injection would more likely gravitational diffuse to the levator palpebrae superioris muscle while standing, opposed to lying. Injection of the platysma muscle to get distinct jawline called the Nefertiti lift, and the décolletage area to relax the muscle and contraction through the décolletage. This is just a guide of how much this sport is used and how much Botox is used as neurotoxins. Complications. The most complication of neurotoxin is Dr. Spock, is the spocking. And this is uneven function of the frontalis and brow, and produced by the activation of the central frontalis muscle, totally deactivated, with incomplete treatment of the lateral frontalis muscle. When the patient raises their brows, the lateral brow elevates and the medial brow does not. So it's easily treated by injecting few units of neurotoxin in the lateral brow or lateral frontalis area. So when treating the frontalis, it's important to inject the muscle all the way to the hairline, so you don't end up with these incomplete muscle, still the spasm happening. And obviously, the most major complication is levator superioris, palpebris superioris paralysis. The other thing is, please do it with under good light, because if you bruise them, they will never come back. You lose them. People don't have time to look after their bruise after a simple injection. So you can use a vein finder to map it out, but also don't take it lightly and make sure that at least you cannot visually see any veins. This is the most feared complication, as I explained before, which is the paralysis of the palpebris superioris muscle. So the most feared complications: unwanted muscle paralysis, the risorius paralysis when you inject the masseter muscle. Attached to it is the risorius muscle, and diffusion through the muscle will lead to uneven smile. And the paralysis of the platysma can be quite fatal and very dangerous in breathing and swallowing. Facial filler injection is the art. The anatomy, knowledge of depth, and safe facial planes. It's about precision, proportions, the use of the appropriate filler for the purpose and where it's injected, good knowledge of the products that are on the market, and you keep in mind, generally fillers do not lift the face until they are done in certain way. We're going to go through just some basic foundation knowledge, and we start by the filler of the nasolabial fold. I'm going to show some anatomy. So here the anterior view after removal of the skin, and we see the superficial fat pads. Then we remove the skin and the superficial fat pads. We'll remove the portion of the orbicularis oculi muscle, the zygomaticus muscles, and the risorius, and the vaccinator also. The most important, or very important, is to know the path of and the depth of the facial artery, its divisions, and the superficial and the inferior labial branches. And it continues as the angular artery that divides into branches to supply the ala of the nose and the dorsum of the nose. Here, this is the angular artery. After it has given the superior labial artery, it becomes the angular artery. Again, here is the the angular artery after it has given its branches to the superior labial artery. So the filler injection technique of the nasolabial fold, using a needle into the intradermal plane. Depth is everything in filler injections, depending on what you need to achieve. So inserting the needle at 30 degrees in the superficial plane, it can be both linear, retrograde, or antigrade injections are all possible. Now, in here, the application of the product in the intradermal plane, you can see the shadow of the needle can be seen through the skin, and the pink area showing the localization of the needle plane above the subcutaneous tissue. Filler injection technique, nasolabial fold, the perinasal triangle to the supra-periosteal plane. So the needle goes perpendicular, applying the bolus, and you aspirate before you apply the bolus. So here we see the blue circle. The product was applied with the needle to the supra-periosteal plane and is visible in green. Here we use the cannula. The product is visible in pink, and a linear retrograde or antegrade injection can be applied, as well as bolus in the area of the piriform aperture. That's before and after filler injection of the malar region and the nasojugal groove. Very noticeable improvement after the procedure. Here we have a patient with loss of volume in the middle thirds of the face. Filler injection in the malar, the zygomatic, and the nasojugal groove. And we can see the area treated, and we see the before and after. Very noticeable difference. Fresh, rejuvenated, very happy patient. We'll talk about the chin and the mandible contour. The lower third of the face, after the skin has been folded back, exposing the superficial fat pad, the facial vein, and the facial artery. And the branches are quite visible. The superficial fat pad has been folded back. The facial vein is more lateral than the artery, which is more medial. The branches of the proximal of the oral commissure that give us the inferior labial artery, and then the superior labial artery, and it continues as the angular artery that supplies the inferior portion of the ala. After dividing into these branches, the facial artery continues its ascending course and becomes the angular artery. Again, the lower third of the face, we've made a window showing the cannula and the mental artery, which is the pinched artery there. The pinched artery of the mental artery. The blue arrow shows the mental artery. The yellow arrow below is the depressor anguli, angle of the mouth has been pinched there, coming out of the mental foramen. Here we've got the superficial fat pad again. And then we have the facial artery branching into the inferior labial artery and superior labial artery. These branch out into the superior labial and the inferior labial arteries. Facial artery pinched here, the inferior labial artery, superior labial artery. Injection of the mentum, that's where the filler injection to the chin, marked for filler injection in the lateral mentum region. The area to be filled here is highlighted. Beware of the jowls. The last thing you want to do is inject in the jowls because it sags. So the lower side of the face, showing the mental superior facial fat pad. In those two sections, the skin is folded and the mentalis muscle being pinched. Again, just to see the anatomy and the depth. Here we see the cannula injected throughout to where it is inserted into the mental deep fat pad behind the mentalis muscle. And that's the green deposits of the filler. Here we are injecting two different positions in the supraperiosteal plane in the chin. We can see the filler injected supraperiosteally, and in here the face show this green, this color is injected with a needle into the supraperiosteal plane of the chin. That's the profile view where the cannula is inserted into the lateral mental region. The profile view of the lower third of the face in the lateral mental region for the filler. The skin here is folded and the cannula inserted into the supramuscular plane in the lateral mental superficial fat pad. And here we see that the lateral mental superficial fat pads, and underneath where the green color is visible in the plane there. So here it's a needle that we are using in the supraperiosteal plane and showing where the dots of the filler has been deposited. Now, here we're talking about cannula inserted into the mentolabial fold. It goes through the intradermal, from the intradermal to the subcutaneous plane of the oral commissure, and we have the position of the filler in the lateral oral commissure. That's the profile view showing the treatment of the marionette lines, and you can see that the green colored is a filler injection of the oral commissure and the mentolabial region of the marionette line. Now we go into the mandibular line, and the marking of the angle is filled with white. This is the white area we need to fill. So here the skin is folded back through the temporal superficial fat pad, and the cannula is inserted. You can see in the mandibular region, the mandibular line, the ramus, and the angle. Here we're filling the zygomatic and malar area, the nasolabial fold, the lateral mental region and the mentolabial sulcus, and the oral commissure. The before and after photos, brilliant results. Here is injecting the central mentolabial sulcus, and that's the anterior view, the mandibular ramus, the mandibular angle, and the mandibular line and chin. That's the right oblique view of the same patient, injecting the malar and zygomatic region, the mandibular ramus, the mandibular angle, the mandibular line, and the lateral mental and chin region. And that's the before and after. Exceptional masculine jawline and beautifully filled malar and zygomatic and nasolabial and mentolabial fold and chin and sulcus. Again, this is the mandibular ramus and also the lateral mental region and chin. That's the same, nearly the same of the zygomatic and malar region, nasolabial fold, chin, and the submental region. Very interesting that it's not just about one area to be filled, but the transformation, the sculpting that creates beautifying features. The before and after, and the before and after. The sag of the mentolabial fold is gone, chin beautifully pronounced and beautifully pointy and feminine. Zygomatic process, the malar region, zygomatic arch, the chin, the lateral mental region, the mentolabial sulcus, the oral commissure, the supraperiosteal filler at the junction of the ramus of the mandible, mandibular line, and mandibular ramus. And we can see the difference. Beautiful results, beautiful chin. The preauricular region and the earlobe. Superficial fat pad, vascularization, innervation underneath, arterial and venous integrated in the buccinator and the masseter muscle. Here we have the zygomatic and buccal branches of the facial nerve that we have pinched here. Filler injection with cannula that's put underneath the skin. So in my presentation on the foundational knowledge of facial anatomy and facial filler injections, I covered the various regions where fillers can be applied, including the forehead, eyebrows, infraorbital area, and malar and zygomatic regions, nasolabial fold, deep cheek fat pads, the oral commissures, the chin, mental area, preauricular area, and earlobes. And we can keep identifying area that needs to be injected down to the décolletage area. I emphasize the importance of precision, anatomical knowledge, and understanding the appropriate injection depth and technique. So choosing the correct type of filler and understanding the appropriate injection depth is key. Choosing the correct type of filler and selecting suitable patients are key factors in achieving optimal aesthetic outcomes while ensuring safety and effectiveness. This approach helps deliver natural and harmonious results tailored to each individual's facial structure.